and the presentation, but that's for afterwards. That's a good thing about all this, that it's recorded and you can watch it as many times as you like. And well, what are we talking about? We're talking about the intrinsic muscles. And if you look at this picture, which again I borrowed from Judy Colditz, you already notice the complexity of this whole system. We have the extensor digitorum communis. So we're looking from proximal to distal. And extensor digitorum communis has its part in this whole mechanism, in this whole cooperation with all the different muscles working on our fingers and what they can do. Of course, we have the flexor digitorum profundus. We have the two interossei. And some have one palmar, one dorsal. The middle finger only has two dorsal interossei. And here we have this tiny little muscle, the lumbrical muscle, which make an attachment between the flexor and extensor. So already looking at this very first picture, you see there is something magic going on to how we move our fingers and how we control that movement. So we are talking about for one finger we have two intrinsic muscles and one lumbrical. There are two extrinsic muscles involved. But for the fourth and the fifth finger, the lumbrical origin is from two flexor tendons, making it even a little bit more complex. The fifth finger does not have a dorsal interosseous. The third palm interosseous is attached to the little finger. And the fifth finger, the little finger, has three hypothenar muscles, which more or less act like a dorsal interosseous, like an interosseous muscle for the little finger. Important when we looking for an ulnar nerve to recover, to see what the hypothenar muscles are doing. And then again, the index finger and the little finger also have an extra extensor. So it's a pretty complicated picture. And I hope to get a little bit more across that you understand how these muscles work together and how it's involved. And all these muscles and tendons, they together insert into this extensor expansion. So I will, after the break, also will take some time to talk about the extensor expansion, because that's essential to understand how the forces are separated and joined in that extensor expansion. So in this finger, it's possible that a flexor can become an extensor. If you look at the flexor digitorum profundus, we know the lumbrical is inserted, but if there's a rupture of the flexor digitorum profundus, what happens? And suddenly the lumbrical acts like an FDP. The insertion is cut or whatever happened, and then suddenly the FDP is transmitting its force through the lumbrical towards extension, and that's what we call lumbrical plus. So the flexor can now become an extensor. The opposite also happens if an extensor can become a flexor. For example, in boutonniere deformity, where the lateral bands, they move to the folar side so much that instead of being extensors, they become flexors of the PRP joint. And we talk about and see some pictures of that as well. Now, another thing that can happen with your extensor is that your extensor works like an MCP extensor. That's the only extensor you have for your MCP joint is the EDC. And it's right in the middle of your metacarpal. But when your sagittal bands are not working properly or damaged or cut or elongated because of rheumatoid arthritis, the EDC is moving towards one or the other side and suddenly becomes a deviator of the MCP joint. So what we say is there's very, very little redundancy in the fingers. You need all the parts, and they have to be intact and attached to the proper tissue. Otherwise, the whole system collapses and you have problems. So look in a little bit more detail, the interosseous muscles. You have 4 dorsal interosseous muscles, and they all have 2 bellies. The origin is from the 2 metacarpals. They are interosseous, they are in between the 2 muscles. And as you can see, they have, Can you see my cursor? Malvina, yeah? Yeah, okay. And you see the dorsal interosseous, they have two bellies. And they insert into the extensor expansion. And there's between 1, 2, 3, 4 dorsal interosseous. And do remember that the dorsal interosseous, they are big and strong, very strong. I will make a point in saying you can't talk about the small muscles. They are short, but especially the dorsal ones are very strong. If you look at the palmar or the volar interosseous, those are small muscles. And you only have 3. And so your fifth finger, the adduction of your fifth finger, your little finger, is the third palmar interosseous. And they are much smaller than the dorsal interosseous. I like to look at these kind of cross-section. We have a cross-section of the hand, and here we have just the thenar muscles of your thumb. This is the metacarpal of the thumb. You see the extensors, and then we move to the index finger, middle finger, ring finger, little finger. And here we have the 3 hypothenar muscles. Here we have the flexor tendons, and this tiny little muscle is your lumbrical. And that's another point I like to make. Sometimes we talk about the lumbrical position or a lumbrical splint. I think we should not do that because it's making the lumbrical too important. They are very special, but they're not very strong. They're very tiny. They're very small muscles. I'll talk about that at the end of the lecture today. But look at these biggies, these big ones. Here we have the 2 heads of the first dorsal interosseous. And those are big muscles. And this is the 2 first dorsal interosseous. And here we have the adductor pollicis. Big. This is your biggest, your strongest muscle in the hand, your adductor pollicis. Of course, very important, not for adduction, but for pinch. In ulnar nerve, we see Froment sign. And Froment sign is a sign of weakness of your adductor pollicis. It comes together with the ulnar nerve problem. But that's your big muscle, your adductor pollicis. Very strong muscle, very important for pinch. Here another cross section. Here's your thenar muscles of the thumb. This is your first metacarpal, second metacarpal, third metacarpal. Yeah, so you know where we are. And here we have a look again at the adductor pollicis, which has its insertion at the third metacarpal. So it crosses half of the palm of the hand towards the third of the metacarpal. And here we have the first dorsal interosseous is the green part, the 2 big muscles between the thumb and the index finger, which is very visible in your hand. And then we have the palmar interosseous, and the second dorsal interosseous, again, more superficial, it's more on the dorsal side. And this is your palmar interosseous. It's a little bit more, the big mass of the palmar interosseous is more towards the palm of the hand. While the dorsal interosseous has its, if you would have a look at your muscles on the back of your hand, you would see the dorsal interosseous, not the palmar interosseous. Yeah? All the textbook talk about, and now we're going to talk about the action of the interosseous muscles, and all your textbook talk about ab and adduction, which is right, but it's not the main action. Another point I would like to make. The ab and adduction is not your main function of your interosseous muscles. But yes, of course, you can assess the function of your interosseous muscles very nicely with ab and adduction. But it's not the main function. This is your main function of your interosseous. The main action of the interosseous muscles is that they are your primary MP joint flexors. It's not the FDP, not the FDS, but your interosseous are your primary MP joint flexors. And together with their insertion at the extensor mechanism, they of course also provide extension of your PRP and your DRP joint, like you see in this picture. So this is your typical action of your interosseous, not necessarily ab and adduction. Yes, of course, ab and adduction is also part of the action of your interosseous, but the main action is this flexion MCP joint and extension of the PRP and the DRP joint. Yeah? Here's another from Primal Pictures where you see they're pulling at the first dorsal and the first palm interossei at the same time. And you see very nicely that it's MP joint flexion and extension of your PRP and your DRP joint. That is your action for your interosseous muscles. And another animation on that side also shows that at the same time. Yeah? And this is a diagram, I think, which shows it all. Here's your interosseous muscles and the lumbrical. I think the lumbrical's been drawn a little bit too big, but for the point, for this point, it's not, it doesn't matter. The point is that your interosseous muscles are on the volar side of your flexion extension axis for your MCP joint. Here we have the MCP joint, and the dot, the point, is the axis for flexion and extension. So if there's a pull from your interossei, it will provide flexion of your MCP joint. And its insertion is on the dorsal side of the PRP joint. Here we have the PRP joint with the axis of flexion extension with the dot in the middle. So it provides flexion at your MCP joint and extension at your PRP joint. So remember that direction it is. And if you want to make a picture on your hand, it's like that. That's their action. They provide flexion of the MCP joint and extension of your PRP and DRP joint. This also is a clinical picture. A patient with an ulnar and median nerve cut, a knife wound. I'm asking him to put the hand in this position. This is his good hand, the left hand. And that's the hand with the ulnar median nerve paralysis. And so this is what I would call intrinsic plus position. In the past, many times this has been called the lumbrical position. And again, because the lumbricals, they are the tiny ones, and the interosseous muscles are the strong ones, it's much better to call them intrinsic plus position. The intrinsics are active. The opposite is the intrinsic minus hand. Here we see a hand which lacks intrinsic function, where all the interossei and the lumbricals are all paralyzed, and there's no way that the patients can make that intrinsic plus position like on his left hand. They can make a full fist, because they still have full flexion, and when they extend, something else happens, which we will look at later. That's this. The loss of intrinsic muscle function causes claw hand. Not a very nice name, but intrinsic minus is a nicer name, more polite name to call this. But what is interesting is that the one claw hand doesn't look like the other one. And there's a reason for that. There's several reasons. This article, and I'm sorry I didn't get the quote on the slide, but that has been looking at all the different positions they have after ulnar nerve paralysis. And they are different. And I will try to explain to you why they are so different and how we can learn from that by, in our hand therapy, how we can treat these patients. But remember, one or the other is different, and it depends on several things. This is one patient I saw, typical, almost classical claw hand. You see that the little finger and the ring finger, they are in that position. The index finger and the middle finger are in a more extended position. Why is that? Because in his case, the ulnar nerve was damaged and the median nerve was still working. So these two fingers have lumbrical function, muscle function. And the lumbricals are just strong enough so they will put those fingers in that position. So that's your typical ulnar nerve claw hand. The same hand here, you already see what he's trying to do. That's another typical movement all the patients with loss of intrinsic, they do. They go into MCP hyperextension, and the moment they are in MCP hyperextension, they cannot extend their PRP joint. And that takes a little bit of explanation why that's happening, but I'll show you later. But that's your typical hand for a hand which has lost the magic of the intrinsic muscles. And here you see a patient much later, after years of having the problem of no intrinsic function. What you see is that they get a flexion contracture of the PRP joint. That's one thing you have to remember as a hand therapist, that they have possibility of developing PRP joint flexion contractures. And that is a progressive thing, a gradually progressive problem they have. So maybe this year they have no problem, but if the introssei are not recovering, they might develop a flexion contracture within a month. So it's something we have to prevent, something we have to work on and explain to the patient that they have to do certain exercises to Yeah? Is there a question?
No, I think someone who just entered didn't turn their mic off. You can please continue. I can put the mic off.
Okay. Yeah. So, and the other thing is what you see developing, of course, is that MCP hyperextension. You see all the atrophy of the muscles, and you see the hyperextension. And that's something also which is a progressive deformity. I have seen too many patients with this problem, and they have very little clawing in the beginning, and they are sent home. Then after several years, they come back and say, can you do something about my hand? And they have stiff PRP flexion contractures, and then there's a problem that they cannot be solved by tendon transfers or whatever. So something we as hand therapists have to know and acknowledge, that we have to prevent this problem from happening, to keep these fingers mobile. But if you just let the patient go and move by themselves without the introssei, this is what is going to happen. So, little experiment. If you put your if you put your MCP joints in full extension, so you put your hands in full extension, and then you try to extend your fingers. So you push your MCPs into hyperextension, and then see if you can extend your fingers. And you see how difficult it is. Yeah, go back to the slide. Why is that so difficult? Because this is the case. The extensor tendon is attached to the sagittal band, and at a certain moment this is tight. So you're pulling on your extensor, and until a moment that you can't pull any further, because the sagittal bands are tight. So if that would not be the case, you probably would be able to extend your fingers without your introssia much better. But your EDC has a limited excursion because of the attachment with the sagittal bands. So that's the reason why you have problems when you put your MCPs in extension to fully extend your PRP joints, because the EDC also have a limited excursion at the MCP joint level because of the attachment to the sagittal band. All patients with introssei loss, they develop this typical position of the hand, which is called Thomas sign, which is not important, but it has a name, Thomas sign. And what does Thomas sign means? That the wrist goes into flexion. And the moment you put your wrist into flexion, you try to extend the fingers a little bit better. And they do this automatically. It's a trick movement. So they're putting more tension on the EDCs to extend their fingers. In the case of introssei loss, function loss. And that's something they will do automatically. And sometimes when the introssei are recovering, they have to dislearn this movement because they have learned to do this for some months, maybe years, and later they keep on doing it while the introssei are recovering. But they're doing this because they are putting more tension on the EDC. So the EDC is pulling the fingers a little bit more out. So it's sort of a trick movement. When they keep on doing that, they keep on doing, putting the wrist into flexion, putting more and more tension on the EDCs to get that extension, you see what's happening. They get more and more hyperextension. First, have a look at this patient. He has a few months of an ulnar nerve problem. This is his normal hand where he's extending, and on the left, in the picture on the right, you see his ulnar nerve problem. And you see the little finger has difficulty extending the PRP joint. The ring finger also a little bit, and the middle finger and the index finger, they still have their lumbrical, so they can still extend their PRP joints. And you already see the difference. Here's maybe some MCP extension, but on that hand, it's more MCP hyperextension. And that's a thing that you will see, that after months and years, they slowly increase their hyperextension of the MCP joint. And the more MCP hyperextension, the more difficulty they will have in extending their PRP joint. So this gradual change is something you have to keep in mind, that this will happen. Have a look at this young boy. He was around 20 years old, and he had this horrible disease of a neuromuscular disease, which is called the hereditary motor and sensory neuropathy, HMSN, or Charcot-Marie-Tooth disease. Maybe you have seen these patients. And the disease is typical that they develop this drop foot, and after that all the intrinsic muscles become paralyzed. And in this hand you see the little finger still has some function of his hypothenar muscles, and so he's using that little finger for extension. Now you see some activity at the hypothenar, but on the index middle ring finger there's no intrinsic whatsoever for some time, for several years. And so he went home some years ago, and he said, okay, if you want anything to do, come back. And he was getting used to it, and by this time he was around 20. He came and asked, is there anything that you can do as a surgeon, as a hand surgeon? And we were talking about tendon transfers. But at this time he had fixed flexion contractures of his PRP joints. And this is something you don't see very often, but after years of loss of intrinsic function, this is what you see. So it tells me that the intrinsic muscles are very important for extension your PRP joints as well. And if you keep on going with this loss, look at the flexion contractures he has. They're more than 90 degrees flexion contractures in his PRP joints. So as a therapist, this is what we want to prevent. And if he has mobile fingers, then we can think about surgical reconstruction, of course, and tendon transfers, which is done also at our hospital in an earlier case than in this case. Yeah? So long-standing loss of intrinsic muscles of the hand, they cause increased MCP hyperextension, and the more hyperextension of your MCP joint, the more the more PRP flexion contractures will take place. So keep that in mind. And this is the steps. Oh, this was an animation, should be one by one. But anyway, this is a summary of what we've just been looking at. So we have extension of the fingers. Remember that the intrinsic there are also the main the flexors of the MCP joint. So there's no opposition by the intrinsic, so they go in more and more hyperextension. And then if there's more hyperextension of the MCP joint, the extension of the PRPs will be more difficult, and so they develop flexion contractures. And if the hand is in that flexed position all the time, what will happen? The flexor muscle will adapt. If you're not using the length of your muscle, the muscle will adapt, which is a physiological adaptation. So they become shorter. And of course, when the muscles are shorter, the more they pull the fingers into flexion. So that's a cascade of problems that what you will see, and making it worse and worse and worse. So, and what will happen at the MCP joint? So more and more hyperextension, the volar plate and the volar tissue of your MCP joint will also stretch and also adapt. And in the end, you might even have bowstringing of your EDC. Your hand is in that claw position all the time, and you're trying to open up your fingers, and the EDC tendon is pulling as hard as it can. So it's also having a movement to the dorsal side, and it will stretch the sagittal bands. And the more the sagittal bands are stretched, the more the EDCs become, they move away from the MCP joint. And you might even see bowstringing of your EDCs. In early cases, you don't see that, but after some years, sometimes this is what you can develop. And the more the sagittal bands are stretched, then again, the EDC might slip off that MCP joint because of the stretched sagittal bands. You see the progression in the deformity. It's a cascade of things that will happen in time. And because you know of this now, you know how to prevent it and how to explain to your patient what to do to prevent that problem from happening. And there are many ways that we can do to prevent that. This is the animation. So going back to the action of the intraosseous, I love this picture, and I got this cylinder with me. That is your typical action for your MCP joint. You remember that's the MCP flexion extension, and look at the cylinder. That action is a typical intrinsic action. Also some flexion of your FDPs, but you can do that with just your intrinsics. Without FDP and FDS, you should be able to do this. Without, it becomes very difficult, and often impossible. Like what you see in that picture here. Now you have loss of your intrinsic, so your flexors, your FDPs and FDS try to hold that cylinder. And then you see the contact area becomes much smaller compared to a full functioning hand with intraosseous muscles. And now you see that the contact area is much smaller. And that's also important for patients who have lost sensation. They have very high pressure points here and they don't feel pain. So they might develop blisters and pressure points. So that also tells me that the intraosseous muscles are important for holding large objects. Often in many books, they talk about the intrinsics of the hand as small muscles important for manipulating small things. Well, you see my hesitation. I think, first and all, it's holding large objects. And of course, the intraosseous is also important for pinch and having a proper and strong pinch, of course. But remember that holding that large object, that is also an intrinsic function. And if you have loss of intraossei, holding a large cylinder like I showed is very important. So here's your typical intrinsic function. See that one? And see holding a brick like that. Or unscrewing a bolt, holding a bottle, holding your Sobotta anatomy book. That's a typical intrinsic plus action. And it's very difficult without the intraosseous function. So look at this video of this patient. And he has an ulnar nerve problem. Left hand is working well. And look at his right hand. His hands look quite good. He's still a little atrophy. Because it's very recent. Left hand, now his right hand. See what's happening? He is trying to have his FDPs holding that cylinder. But if he's activating his FDPs, they will slip off. He needs that MCP flexion to hold the cylinder, and then the FDPs can come in. But in his case, he has no intrinsics of his right hand, so he's lacking that MCP flexion. So he's getting into flexion of his DRP and PRP joint, and then you can't hold that cylinder. See? So the FDPs help here. He only has FDPs and FDS in this hand, but that's not helpful in holding a cylinder. If it's small, of course, it will work, but if it's a bigger one, it will not be possible because he's lacking that MCP flexion force of his intrinsics. Another very recent injury of a patient, you see in his the top one, you see very little clawing. he can almost fully extend his little finger. And in this time you say, that's a minor problem. Congratulations, and send them home. And then after 1 year they come back with a stiff flexion contraction of the PEP joint. Remember, this can take place because now his MCP joint is sort of has enough resistance at the volar side of his MCP joint to prevent that hyperextension. But when he's going to use his hyperextension, the tissue at the volar side of his MCP joint will stretch. And the more it stretches, the more clawing he will develop. So in this case, yes, it's wonderful that he's not having a very aggressive claw hand. But remember, in time, it can develop. This is a very nice exercise I like when there are very weak intrinsics. And I ask them to put the hand on the table, and sometimes it doesn't work, so I have the other hand to help that little finger, ring finger, to hold in that position, and then I ask them to pull back. See, the hand is helping, and to hold it there. That needs minimal activation of your intrinsics, and now he's going to pull the hand backwards. So you need minimal activity of your intrinsics here to do this exercise. But that's a very good exercise for very weak intrinsic muscles. And then you can develop in having them hold it and stretch out and then flex again. But to start with a very minimal activity, this is an action I like, an activity I like. The other thing that I think you already know is that when you're having the patient with intrinsic loss, again, remember they can make a full fist. There's some problem with flexion, but they can make a full fist. And they sometimes have a strong grip. But the way they make a fist is different. If we make a fist, it's often flexion of the MCP and then the PRP and DRPs come in. But of course, when you do not have intrinsic working, you have DRP, PRP, and then in the end you have MCP flexion. That is another reason why it's so difficult to hold a large cylinder. Because you are flexing with your FDPs and FDS and you can't open it anymore. And this is a nice study where they did the measurements on cadaver, where they looked at, so how does that affect the flexion? And they found in this altered joint flexion that the closing of the fingers is much more difficult without the interossei. So there's several reasons why it's better to have that MCP flexion, PRP, DRP in that sequence, in that order. And if the intrinsics are paralyzed, you see that the FDPs take over and they flex the DRP, PRP, and then at the end the MCP joint. So that's something which has been measured in this very nice study. The other thing you need to remember is what is the influence of this long flexor, the extrinsics. And we have running a course here on hand therapy, and this is one of those typical examination questions. Which patient has more problems with clawing? The one with a low at the wrist level or a high elbow level ulnar nerve lesion? And they all think, well, low is not that big of a problem, so they mix the answer. So what do you think? What is... No, I think I already gave it away, sorry. Anyway, so why is it that in a high ulnar nerve lesion, you have less clawing? Which, by the way, is called the ulnar paradox. The higher the lesion, the less the clawing. Why is that? Well, because of the long flexors which are paralyzed are not pulling the fingers into flexion anymore. So the moment your flexors are working, they also have some tension on the fingers and pull the fingers into flexion. So that's the other thing you have to remember as a therapist. When you have a high ulnar nerve lesion and the nerve is recovering, the flexors recover first, right? And so you have more of a pull on your fingers into flexion. So two things to remember is to keep those flexors at good length. The shorter they are, the more they pull the fingers into flexion. So it's a good exercise in loss of intrinsics to keep the long flexors at good length. So to do stretching exercises like this, or maybe even splint. The knuckle bender. I must confess that I was not much in favor of a knuckle bender. Some of the knuckle benders, they don't work properly, and often the design is not being done very nicely. For example, the distance at this side, you should be as distal and here as proximal as possible to get a good leverage, to get a good moment arm. But although I was quite negative about knuckle benders, I have changed my opinion. Because what I see, and one of my colleagues, she explained that to me, the patients using a knuckle bender, they keep on moving in a proper way. So they are preventing that MCP stretching. They probably are also preventing flexion contractions of the PEP joint. And there's also something into a cortical process that will maintain their normal movement instead of that. You remember the Thomas sign, the Thomas movement, and so they're not all the time stretching the MCP volar tissue, and they move in a more normal way, which is probably something that is also effective to keep that normal movement within their brain. And might be helpful in regaining normal function afterwards. Another thing that's often forgotten about introsis muscle strength and muscle weak, that some patients they complain about weakness of their grip. And this was in my PhD that I looked into the measurements, and I found no relation between grip strength and intrinsic muscle strength. But still, patients complain about a weak grip, and I think it might have to do with the fact that if you look at the arch, this is a normal hand with a curved arch, and this is a hand with an ulnar nerve problem, and you see the flattened arch. And first of all, that tells me, hey, that arch is a function of your intrinsic muscles. And maybe you want to have a look at your hand. And Koen, can you give me a close-up? So if you look at your hand again, and if you have this activity, see this one, and you're pulling your hand, you're squeezing your hand, and now feel your hypothenia. You feel that is an intrinsic action. And if you look at your knuckles, you see the arch of your knuckles. This is an intrinsic action. And if the hand will maintain this sort of flattened arch, and when you're holding something like a hammer, can we go back to the slide? Holding something like a hammer, and you cannot pull your fingers around, that is probably a sign of having a flattened arch because of the weakness of the introsi, rather than having a weak grip. And so that action is also an action of your introsi, the arch of your palmar metacarpal. Another thing, or an action of your introsi, is rotation. And something we hardly look at is that there's a rotation is possible within your metacarpal joint. This is your metacarpal joint, MCP joint, and your proximal phalanx. And if you pull on one or the other introsi, there also will be some rotation of your finger. Probably for musicians playing the violin, something they make use of, and also baseball players, how they you see some of the rotation of that index finger and the middle finger. They holding a round object like that. There's some rotation also in your fingers, and that is a function of your introsis muscle. And some will complain about weakness, but it's probably rather that the lack of coordination of your finger movement in rotation that they lack rather than the real weakness. This is something very different. We talk about CMC1 arthritis. And Corey McGee, he's from America, or was it Canada? I think America. Anyway, it's in the Journal of Hand Therapy. And he looked at the effect of training your first dorsal introsis and the effect on the metacarp of the thumb. This is an X-ray of patients with CMC arthritis. And what you see is this is your trapezium and your first metacarpal. You see the dislocation in rest. So in rest there's some dislocation, and on this side they are activating the first dorsal interosseous, and you see that the metacarpal is being pulled into abduction, and so they are telling us that the first dorsal interosseous might have this influence of opposing the function of the abductor pollicis longus in pulling the metacarpal from the trapezium. And so we have also been adding first dorsal interosseous strength movement for patients in the early stage of CMC arthritis, and also where some subluxation takes place. Yeah, so that's also interesting function, and it's because of the two bellies. The first dorsal interosseous has its origin on the first metacarpal and on the second metacarpal, and so that pull might be something you also want to look at and do for training in your patient with early CMC1 arthritis. So going back to statements about intrinsic muscles, this is what we sometimes hear: they are small muscles. And the moment you say small muscles, you also might think about, they have little importance or small importance. Well, I hope you will not think about that after this lecture. They are big muscles, some of them are very big, and they are important in many ways. And this again is a nice diagram from Paul Brandt's book, The Clinical Mechanics. And what you see is that on this axis, the further the way are to the right, the longer the muscles are, the more excursions they have, and the higher up they are on this axis, the stronger they are. See? So flexor carpial nerves, the supinator are the strongest muscles you have in your lower arm. But look at these four muscles. This is your dorsal interosseous. The first dorsal interosseous is halfway this axis, and it's on the same position as your FDP, your middle finger. See that? Your FDP, ring finger, little finger, index finger, they have the same cross section, they have the same strength as your first dorsal interosseous. And here's your adductor pollicis. See, they have the similar cross section area as your FDP and your FDS. Wow. And so you should not talk about the muscles as if they are insignificant in strength. They are very significant in strength, and they have comparable strength to your long flexors. Well, and then again, if you look at all the way down here, you see your four lumbicals. So they have very long excursion, but they are very weak muscles. So that's something we can learn from this diagram. So you should hesitate from now on to talk about the small muscles. Short muscles, yes, compared to extrinsic, they are much shorter, but they're not small. Some of them are small, but not all of them. So just before the break, a little thing about intrinsic tightness, because we're mixing up, I see my colleagues, students, they're mixing up the paralysis and the tightness. So let me just say something about intrinsic tightness. So we are not talking about a paralysis, but we're talking about shortening of the intrinsics. And why does that happen? Well, first of all, the intrinsics are in compartments. They are interosseous, so they are in between the bones. And they have their compartments. They have this strong fascia around the dorsal and the volar compartments, the muscles. They all have these different compartments. And these compartments, they are fascia type of tissue, tough tissue, which doesn't allow for a lot of stretching. Your palmar skin is attached to these fascia. And that's why you cannot move the skin. On the back, no problem. You can move it forwards and backward, but not your skin on this side, because there's this anchor system attached to this fascia system, which also creates compartments of your intrinsics. Here we are. This is your bone, and here are your compartments. See the fascia and the muscle within? This is tough tissue, and it doesn't allow for stretching. So the moment you have a trauma and swelling, you should think about compartment syndrome. These compartments, they don't allow for a lot of stretching. So the moment there's a swelling inside this compartment, the tension goes up. And if the tension goes up, your blood flow might stop. So part of your muscle might die because of the swelling. And if a muscle has lack of oxygen, there will be a fibrosis within the muscle. The muscle tissue will die, and instead of that comes scar tissue, comes tissue that is not related to the muscle anymore. And it will be fibrosis, we call it fibrosis. And this is typical intrinsic tightness. Patient had a metacarpal fracture, and after some time, he came with complaining of his PRP joint. And there was this click, see? And that caused pain in his ring finger. And it was a late development of intrinsic tightness after swelling in his hand because of a metacarpal fracture. And this is the test. You're holding MCP in extension, and you see how much flexion there is compared to when you allow MCP flexion. And you see the difference, and this is telling you there is intrinsic tightness. The intrinsic muscles have shortened, have been caused, there's fibrosis within the intrinsic muscles. And when we remember this picture again, you remember that the direction. So the MCP joint is pulled into flexion because of the fibrosis, the shortening of that muscle. And the PRP joint is pulled into extension, into hyperextension. Continuous pull because of the shortening causes PIP joint hyperextension, which we call Swanneck. And so intrinsic tightness causes Swanneck deformities. So you have to remember that if there's any swelling in the hand in the anamnesis, in the history, then you should test for intrinsic tightness. And a very quick, easy test, of course, is to ask the patient to make a hook fist. Because if the intrinsic are tight, they cannot extend the MCP joint and flex the PRP joint at the same time. So that's a quick test for your intrinsic tightness. Okay. Maybe questions for now, or pause first and then the questions?
We can take a break first and then have questions.
Okay.
During the break, you should click on the chat function and go to the document and write your name so that we know who is listening today.
Okay.
Så att det borde vara om hur många människor som lyssnar. Yeah.
Okay.
So 5 minutes?
See you in 5 minutes. Yeah. Okay. Yeah. Everybody back? Any questions, Malvina?
Not really, no.
Okay. Shall we proceed then? That's enough to... Yeah?
Yes, please do.
Okay. Okay, here we go. So... waarom zie je mijn volgende dia niet?
Ik heb met de muis even activeerd het scherm.
My slides are not working. Let me see. Yeah. Okay. Next part is the extensive expansion. And I think if you do not understand how the extensor expansion works, you will have difficulty understanding how the intrinsic muscles work on the finger. First of all, there's many different names, and I usually call it extensive mechanism. I know Judy Colditz, the famous hand therapist from America, likes to call it dorsal apparatus. And she makes a point that the extensor mechanism is not just for extension. Remember, we said flexion of your MCP is an important part of your intrinsics. So she likes to use the word dorsal apparatus. But anyway, all these names are being used in literature. So remember that there are different names for one and the same thing, which is the extensor expansion as it is in this picture. EDC towards the central slip, lateral bands all the way to the end at the DAP joint. Here's your PRP joint and the interossei and lumbrical muscles that come and join the interossei into the central slip and into the lateral bands. So if you make a diagram, at the course we made this drawing at the course time, but maybe later you can look at it again and make your own drawing. So first of all, the green line comes in from proximal at the MCP joint. Just beyond the MCP joint, it separates into a central slip and into lateral bands. So this is the extensor digitorum communis, central slip and the two lateral bands, all the way joining into the terminal tendon at the distal phalanx. We have two interossei, and of course they have their parts into the central slip, and they also join the lateral bands of the EDC towards the terminal tendon. So I think you're all familiar with this. Remember, the sagittal bands are important to keep the EDC at the right spot on top of the MCP joint. And so let's move on to the next one. Sorry, something. That triangular ligament. The triangular ligament is important to keep the lateral bands at the right spot. And I will talk about that a little bit later. But first of all, look at the EDC. We have the EDC separating into a central slip and into lateral bands. And you have to understand that this cannot move independently as long as they're all intact. So if you're pulling on this side, you're pulling on the central slip plus the lateral bands. Yeah, you cannot say, I just want to pull on the lateral bands. It's impossible. They are connected. They are in one part. So if the central slip is not moving, the lateral bands cannot move. If you're pulling here as hard as you can, if the central slip is fixed, then the lateral bands cannot move. But if you cut the central slip, then suddenly, of course, when you're pulling on the EDC, then the lateral bands can move independently. So when the central slip is disrupted, then the lateral bands can move independently. And that's the basis of this test, which is called the central slip test or the Elson test. I made this drawing some time ago and published it in the Hand Therapy Journal in 2006. After that, many times being copied in many articles without reference, but anyway, that's part of the problem of copying things. But basic of Elson test is in a normal situation, your central slip is fixed into PRP joint flexion. So if you're holding the PRP into flexion, if you're pulling on the EDC, you cannot extend your DRP joint because it's connected to the central slip. So in a normal situation, If you're putting the fingers together, you cannot extend your DRP joint. If you cut your central slip one way or the other, then now when you're pulling on your EDC, now you can extend your DRP joint. See? So the ability to extend your DRP joint in this situation is a test for the central slip. And it tells you that there's a central slip lesion. So when we have PRP into extension and we're flexing our DRP joint, then of course lateral bands plus central slip are being pulled distally. Yeah, that's a normal situation. When you have your flex your DRP joint, you're pulling on your terminal tendon, and then central slip plus the lateral bands, they're all being pulled distally. But if there's a central slip lesion, now what will happen when you flex your DRP joint? Then of course the two lateral bands will be pulled distally, and watch what happened to your central slip. So in this case, I made a central slip lesion, and I'm sorry it's a bit of a poor video, but there's a central slip lesion, and now you see the gap, and you're flexing your DRP joint. Now you see the gap has become smaller. So that tells you that the lateral bands are being pulled distally, and the central slip is pulled with your lateral band distally and closing the gap. This one is a bit better. Here you see again the central slip lesion, you see the gap, and you see that when the DRP joint is flexed, then the gap is closed. Your lateral bands are being pulled distally, and so your central slip now has been closed. And that's an important thing to know, that when you have a central slip lesion, it's better to leave the DRP joint out and actually have the patient exercise DRP joint flexion, because in that way the central slip is being pulled distally towards the gap, towards the other stump of your tendon. A little side step here. In a mallet finger, remember that when you have your PRP joint flexed, that you cannot extend your DRP joint, it's sort of loose. Well, in mallet finger, when you have this tendency towards a hyperextension, and you want to be very secure that there will be no tension on your terminal tendon, it might be a good idea to block your PRP joint. See this joint, this splint is blocking extension of your PRP joint. Well, the rationale behind this is that when you put your PRP joint into flexion, you see there's no tension on your terminal tendon, which might be profitable for recovery of your mallet finger. The second advantage of an extension block is, and that's what we do for all the patients who have a tendency towards a swan neck, a hyperextension. So to block the extension of your PRP joint. And by knowing now the mechanism behind this, you know also the rationale that you're putting less tension on your ruptured tendon. So it's a good, in two ways, it's a good thing to do to block your PRP joint extension. Looking into the lateral band movements, and we talked about the central slip, now we're moving to the lateral bands. You should realize that when you're flexing and extending, your lateral bands move. They have to move to adapt for your extension or flexion. And this is sometimes called the Winslow diamond. In flexions, the lateral bands move outward. You get another diamond shape. And into extension, you see that the diamond becomes smaller and the lateral bands move towards each other. That's a normal situation. So which one is extension? Left or right in this case? Look at the central slip, number 1, lateral bands, number 2. And you see that these lateral bands have been moving up. So then you know this one is extension and this one is flexion. You see that the lateral bands move towards the flexion-extension axis. Yeah? And if in extension, they move away from the flexion-extension axis. So actually, that also tells you that in extension, the distance is increased. Your lateral bands move up in extension, so the distance towards the axis is increased. So the moment arm is also increased. So that's an advantage. So the lateral bands give more extension in extension, and the lateral bands give less extension in flexion, which sounds to be a sound system. And so remember that they have to move up and down, and the more into flexion, the less extension forces it creates at the PEP joint. Lateral bands can move in the hypermobile fingers even further away from the bone, and then you get this situation of a severe swan neck deformity. And now you see that the lateral bands, they even bowstring at the PEP joint, moving away from the joint, increasing moment arm, increasing force. So this is also something you might have a gradual increase of deformity, and something to prevent, because the forces of the EDC increase the further they get away from the joint, the more bowstringing there is. So these lateral bands have to be controlled, and we looked at the triangular ligament. Now we're looking from the side, so we have the EDC from the side, and here we have the introssei, and they come with their joining the central slip, and another part joining the lateral bands. And you need tissue to control the lateral bands, and those are two retinacular ligaments that I would like to show you. Here, of course, we have the sagittal bands controlling the EDC, and the triangular ligament. Those ligaments, they keep the lateral bands dorsally, and they are here. And so here is the PEP joint, just distal of your PEP joint. We have the two lateral bands, and in between we have the triangular ligament. And they are attached to the lateral bands. Here again, we're looking from the top. This is your PEP joint. We see the lateral bands, and this tissue in between the lateral bands keeps the lateral bands dorsally. That's the triangular ligament. Here you see a flexion of the finger. You see the lateral bands on the side in the cadaver. You see the tension on this tissue in flexion. So this flexion is tension on the triangular ligament, and you need tissue here to keep those lateral bands at the right spot. So the increased tension on the triangular ligament when there's flexion PEP and flexion DP joint, then you have the maximum forces on your triangular ligament, which is important when you have a central slip lesion to realize this. Here we have a central slip lesion. The lateral bands are intact, so often in an early case you can still extend and flex your finger because the triangular ligament is still intact. So you have a full central slip lesion and you can still extend and flex your fingers as long as the triangular ligament is keeping those lateral bands at the right spot. But if you cut, and this has happened in meantime when you have a central slip lesion, that this tissue stretches or also gets damaged, then the lateral bands, they can move more volar, and then you have your problems of maybe a developing boutonniere deformity. So this is your triangular ligaments, keeping the lateral bands dorsally. The other ligaments, the transverse retinacular ligaments, they prevent the lateral band from moving too much dorsally. And so those two control the position of the lateral bands. And if you want to get into more detail, the Pulvertaft has, during the Corona crisis, they made these videos and webinars. And Dr. Alberto Yuc is one of the Spanish surgeons, and he has a very nice presentation also on this kind of problems. And this is one of his drawings. And you see the stabilizers of the lateral bands. We have these retinacular ligaments, and here we have the triangular ligament. And they have to keep that position of the lateral bands at the right spot. And that's a matter of millimeters. Any damage, any change, any elongation, any infection, any shortening creates a disbalance in that system. So remember, the lateral bands move up and down in flexion and extension, and the position of the lateral bands are controlled by these ligaments, the triangular ligaments and the transverse retinacular ligaments. And they keep them from slipping up dorsally. Yeah. So can you do without a central slip? Yes, I would say for some time. And this is a typical thing that you see with a central slip lesion. Patients have a cut at their PEP joint and they have no acute loss of extension. It develops in time. Here again we have this sort of gradual increase of deformity. So because of that triangular ligament slowly also maybe separates or gets damaged or elongates or whatever. So yes, you can, as long as the lateral bands are at the right spot. So as long as these two ligaments are functioning, then your lateral bands can take over the extension and flexion at your PEP joint. So remember that also explains why you do not have a boutonniere in an acute stage. It comes later and it develops later. The relative motion flexion splint is interesting to think about also. That some people would say that if you have a central slip lesion and if you put the MCPs into flexion and they can extend the fingers like you see with the pencil or with a little splint, that means you're pushing the lateral bands up again. Rather, I would say pulling them up again. Look at your finger when you're pushing your MCP into flexion, then your PEP joint extends. And that is because you are putting more tension on your lateral bands. And in doing that, your lateral bands become a little bit more dorsal, so become a better extensor of your PEP joint. So some would say if patients after a central slip lesion, and they can extend the finger with a relative motion flexion splint, that probably is enough to protect that central slip, so that it can heal and the two ends can already join and come together. So I already explained about the treatment of a central slip, and the central slip is very much similar. The treatment is very much similar to treating a mallet finger. There's often no need for surgical repair unless there's an open wound. Then of course it's much easier to repair at the same time when they're cleaning the wound. But otherwise you can treat a central slip like a mallet finger. And when you're putting the finger into extension, then you know that the two ends will join, especially when you're flexing your DAP joint. Like we said before, you're pulling the central slip distally. So in that case, the two ends of the lesion, of the injury will join, because now they are attached, just like a mallet finger. So let's skip that. So finally, lumbricals. Those are the mini muscles with secret skills. And they are very, very special. And remember, they are small and not very strong, but yes, they are the special ones. So lumbrical is if you look at the dictionary, it says lumbrical means pertaining to a worm. So I think that's a nice metaphor. That if you look at the lumbrical, you think about the worm, which is significant but small. And here again is your lumbrical muscle, and a very, very special muscle. There's no other muscle in your body that has an origin from a tendon and an insertion into a tendon. And in your fourth and your fifth finger, even from two flexor tendons. Wow, making it more and more complicated. So that lumbrical is a very, very special one. And here some nice diagram of how this goes. See the two muscle bellies from one flexor and from the other flexor, which is like an interosseous muscle with two heads and joining into one insertion into the extensor expansion. And this is a nice article with a nice title, which I really like. The lumbricals are not the workhorse, and I think I would fully agree with that one. And which they also proved by cadaver studies, is that they are not the strong ones, they're not the workhorse, but they play an important function in perhaps playing a violin or playing an instrument, because they give information to the system about the forces in flexion and in extension. So lumbricals,
Can I ask you a question?
Yeah.
And so there's a question from Linda saying relative motion splint is for injuries in PIP, but not in MCP, is her question.
No, yeah, that's correct. So it's for PIP joint. So it is for central slip. So if your lateral bands are damaged, then you can't do it. But if you have an isolated central slip lesion, you can use a relative motion flexion splint. I must say there's not many places that do this, but I know Donald Lalonde, who's been involved in this wide awake surgery, he would advocate this, that you use the pencil test to see if they can, in flexion, they can extend the PAP joint. And if so, it's probably a matter of some weeks that you give this splint and see if it heals, like a mallet finger treatment. But of course, at the MCP...
flexion and extension, I think maybe they didn't realize relative motion flexion versus relative motion extension.
Right.
Right.
Yeah. Yeah, okay. Yeah, so at the MCP joint level, you want an extension split for protection. Yeah, so for, at the PAP joint central slip, you want a flexion one. And in flexion, your lateral bands are pushed dorsally, so your lateral bands take over, if you like. Yeah? And protect your central slip in that way. But most people would still say just to immobilize the PAP joint and extension is easier maybe for the patient and also does the job. So if you want more protection, you're pretty sure that the patient maybe will have difficulty in the splint, to have a little splint immobilizing the PAP joint in extension does the job maybe as well. Yeah? Okay, so the lumbricals are not the workhorse, but they are important for these fast movements and for proprioception. Like also in this article, the lumbrical muscles are full of these organ, spindles, rich, and they have a high innervation density, and probably important for the sensory feedback of what's happening in your hand and in your flexors and in your extensors. Yeah. Lumbrical plus I already told about. And now when you have a cut of your flexor, then suddenly your flexor through the lumbrical becomes an extensor of your PAP joint. And this is what we call the paradoxal extension of the IP joints while attempting to flex the fingers. So the more they flex, the more the fingers go into extension. And I got this video of a patient that they try to flex, and when you put the fingers passively into flexion and you say hold it, and then you see the finger extends. And that's a moment that you have to think about this lumbrical plus possibility. Of course, there's more possibilities that maybe your flexor is adhered and it cannot cannot put the forces on the fingers that well. But think about lumbrical plus when you have this patient saying, the more I try to flex, the more my fingers extend, then you have to think about the lumbrical plus problem. There's other things also in amputation. When you have an amputation of the top of your finger, then of course your FTP also is not functioning, and you might get hyperextension because of this lumbrical plus phenomena, which I've seen several times. This is most of the times it's this kind of problem you have with amputation, and then you have a patient that when they try to flex the finger extends. And the treatment is simple. They have to disconnect the lumbrical to take care of that problem. So lumbricals are relevant, yes, especially in ulnar nerve. We have this hand where they're just strong enough to prevent flexion contractures for the index and the middle finger. But like we see in median nerve palsy, there's no lumbrical working in the index in the middle finger. And they are not missed. So the patient is not complaining about much of a problem of this missing lumbrical function. So 14, yeah, we are here, 2:30. So the magic of the intrinsic muscles, they never ends. And there's many more things to say about it, but I hope this helps you forward to discover more and more magic and secrets of these intrinsic muscles. So if you have time for questions, just go ahead. Nobody throwing tomatoes, pears, apples. No. That's the other good thing. No possibility
Will
of.
you have your references and the slides?
Yeah. Yeah.
Cool.
So, are you having a recording, Malvina, or should we send it to you from here?
You can send it to me from your studio.
Okay. Then I will do that next week, and I will also make a handout from the slides, so
That would be amazing.
you can have them as a PDF.
Great.
Okay.
No questions? No.
No. Well, I hope it was clear.
Thank you so much, Tom. This was great.
Welcome. Okay. Good.
Have a good one. Happy St. Nicholas.
Okay. All the best. Bye bye.
All the best. Bye.